Today, I have Dr. Raymond Perrin here. He is an osteopath, a neuroscientist, and specializes in chronic fatigue syndrome and myalgic encephalomyelitis, and now is working with long COVID patients as well. He also has had extensive experience training top sportsmen and women, including Olympic athletes, in addition to stars of stage and screen in his previous practice as well. Now, Dr. Perrin's research since 1989 in chronic fatigue syndrome, ME, has expanded our knowledge of diagnosis and treatment of these neurological, physiological problems. And I was just looking on Amazon. I was looking at your stuff a little bit there, and it looks like the second edition of your book, The Perrin Technique, has just come out as well in March, I believe.
Yes. Okay. Hi, Laurie, and hello, everybody. So basically, we want to talk about in this interview. I think we want to talk about long COVID, chronic fatigue syndrome, fibromyalgia, and as we say in England, the kitchen sink. Everything. Right, and we have about an hour to do so, which is quite a interesting task for me, but you know, I like challenges. So it's, as Laurie said, it started in 1989 with my work. At the time, I was a sports osteopath treating top sportsmen, Olympic sportsmen, and one of the groups and teams I was treating was a top cycling team in the north of England. The north of England has generally, for the last many years, actually been the sort of centre for cycling in Britain. The famous Sky team was all centred in the north of England, in Manchester, which is where I work. One of the members of this cycling team, which is called the Rally Banana team, came in. He hadn't been cycling for 7 years, but he was recommended by one of the members to come in to see me, and he had ME. Now, in those days, we used to call it, well, it was known derogatively, unfortunately, it was called yuppie flu. It was the name yuppie flu was actually termed by the Times in London in a derogatory manner, saying, yeah, well, it's all these young, upward mobile professionals getting this so-called flu virus. And we were given one lecture when I was training in London as an osteopath on psychosomatic disorders. And this was featured in that lecture, that ME was just a mind thing, and you just tender loving care, you can help them. So when he came in and said, I've had 7 years of ME and I've not been cycling, but I've got this back problem. I said, well, I was an osteopath, I can treat your back. So I worked on his spine, I worked on his pelvis and his upper thoracics. And that's the top of the back for the uninitiated. And his back pain disappeared because that's what he came in for as well. But also, as time went on over the next few weeks, his symptoms of ME started disappearing. And after a few months, he was completely symptom-free. And he said, I've been everywhere around the world. Sorry?
Yeah, was he coming to you continuously? Was this after
He came weekly. He came weekly to begin with. And then after a few more weeks, he was getting better, and I spaced out the treatment to every 2 weeks, then every month. And I would say within a few months, he was completely better. And he's been well ever since. And that was 1989. But he was so convinced that whatever I did had got him better, because I wasn't. I thought, well, it's just, how could I have done that, you know? But he brought me a whole wad, and you get these patients sometimes bring you a whole wad of information and say, read this. And he had loads and loads of stuff about ME that had been printed out, and some research papers that he had. So I read through it all and I was interested. I'm always been curious. And what I found was there was a link between ME and the sympathetic nervous system.
Mm-hmm.
There was quite an obvious link that the symptoms seemed to be most of the symptoms of when somebody has what was termed in osteopathy as sympatheticonia, or sympathetic disorder, dysfunction of and the sympathetic nervous system is part of the autonomic nervous system. It's a nervous system that's there for fear, fight, and flight, as they say, to help your body cope under stress. And it was this system that seemed to be going wrong. And I was working mainly on the thoracic spine with him. And that is one of the main areas of the sympathetic nerves. As they travel out from the spine, they go down in two channels on either side of the spine. And the sympathetic nerves run along the thoracic spine from the top of the thoracic spine, which is known as T1, till just below into the lumbar region. And these sort of long sympathetic chains then spread out throughout the body, and they control blood flow, and they control the organs, the heart, the bowels, and the lungs, all the different organs. But one thing I didn't know at the time, which I learned later, they also control the lymphatic system.
Oh.
Now, the lymphatic system is a system of drainage that we have on top of the blood. We need two forms of drainage. And the question is, why? Why do we have two drainage systems in the body? Isn't the blood good enough? So let's talk about toxins for a moment. All makes sense. Toxins.
Okay.
You hear the toxins all the time. What's a toxin? Toxins are anything that really, in a broader term, are anything that's poisonous for the body.
Mm-hmm.
And the body will get rid of toxins through small toxins, small molecules will go through the blood. The blood capillaries, where the exchange of fluid from outside the blood into the blood goes through the capillaries, and the capillary walls are like a mesh, like a filter, and small molecules will go through that. Larger molecules can't get in. So if you have a large molecule, it won't get in there. So we need another system that drains away the large molecules. And that's where the lymphatics come in. The lymphatic capillaries they're tubes as well, but they have an end, and that's why they're also called terminal lymphatics. And their walls are have got like gill structures, like gills of a fish, opening and closing, allowing huge molecules to go in. So that's why we have a lymphatic system, and that system goes through the body and eventually comes out into the left subclavian vein, which is around this area, and that drains away into the blood. And then in the larger blood vessels, it then goes through, eventually into the liver, and the liver detoxifies. And that's how the body works in draining off toxins. At the time I saw the cyclist, I had no idea of this at all. This is something that I discovered later on. But the one thing I did know is the sympathetic nervous system came from the part of the spine where I was working on it. And I said, it must be sympathetic disorder. And I've relaxed the tissues off. I've got the spine moving. It's helped the sympathetic nerves work better. And that's how I've got you better. And he said, yeah, that's it. You've got to look into this. So I did. And I've been looking into it for the last 32 years. And I'm still looking.
Gosh. Yeah.
Yeah. So I went further with that. I went to the university with it. I then started looking more. And when I discovered the lymphatic system was connected, and then I started seeing certain signs of lymphatic engorgement, of congestion, I then thought, well, this is crazy. This is something I didn't realize, that the sympathetic nerves control the lymphatics. And the lymphatic system, the main duct of the lymph is this thoracic duct that goes into the left subclavian vein. This has a pump, and it's controlled by sympathetic nerves. And we were always taught there was no pump of the lymphatics. Lymphatics, we were taught, are pushed along by blood vessels and muscles around that squeeze the lymph up like a tube of toothpaste in a way, going up. But they actually intrinsically have a pump. But we now know that there's smooth muscle walls all around the lymphatics that actually pump the lymph. And the main pump, the thoracic duct, has a pump around 4 beats a minute, which pumps into the bloodstream. And when the sympathetic nerves go wrong, instead of pumping out, it can pump the wrong way. And if it pumps the wrong way, you're going to get what was termed by Professor John Kinmonth in London in the 1980s, shortly before he died. He published a book on the lymphatics, and he talks about varicose megalymphatics. So lymphatics, like varicose veins, but become really, really large and engorged. But you could never prove that these existed. The scanning techniques in those days were very poor, and the scans he produced, his critics said there were very nice pictures of scans of white vessels and black background on the scans, very nice pictures of varicose veins. He couldn't prove there were varicose lymph. So his ideas unfortunately died with him, but I was able to resurrect those ideas and go further. And as what we'll show you now in my little lecturette about it, because I've got a few slides that actually show the points quite clearly.
That would be great. And are you going to be going through what does happen when the lymph goes the wrong way?
That's the whole point of neither, but it's much better. A picture paints 1,000 words, and if we can actually show this to the audience about it. So we're going to start. Actually, that's not the start of the lecture. I'm going to share my screen in a minute. Right, okay. So it's just we'll share screen now. Okay, right. Okay, you can see that now?
Yes.
Okay, we're going to do this little slideshow, and then we'll come back to answer any questions you have, or Laurie, or you can ask during the lecture. Right, okay. So here we are. Start with current slide. Okay, so we have, so this is me. I'm at the moment I'm attached to 2 universities. I'm an honorary senior lecturer at the Allied Health Professions in the UCLan, which I've been done a lot of research work, and I currently am also a clinical research fellow at the Faculty of Biology, Medicine and Health and the School of Health at the University of Manchester, UK. And so there's much research we need to do to confirm, to make more confirmation before all my work is accepted, but we're going on the right track. But unfortunately, everything takes time. And when you're a lone gunman like myself, it takes longer. 32 years on, I've achieved something. And I've got as I'll explain, I've got the health service in England, the National Health Service, some quarters in the NHS interested in my work now, finally. So this is not the first patient I saw, but this is a classic patient we see. And when I saw this cyclist, I noticed other patients coming in with very similar spinal problems. And if you look at this spine here, it should normally curve out and then curve inwards here. And this is curving out there, and then it goes very flat in the middle, and then goes out further down. And this is classic distortion of the spine, which we call Sherman's or osteochondrosis. And it happens in very sporty people when they're growing, especially during teenage years. And this is what we see with many patients with ME, CFS, or fibromyalgia as well. They're very active before they get ill. Mm-hmm. This spine would, if it was that shape, it would restrict the drainage of fluid out of the spine. And we'll talk about that very shortly. So we talked about the sympathetic chain, and we talked about there's that the chain of sympathetics go down the spine, but there's two parts of the sympathetic. There's the afferent and the efferent. The afferent is a sensory component that sends messages to the brain and from different parts of the body, from the blood, from the internal organs, and it then you have the efferent coming out. Now, for years, they've always believed that the sympathetic nervous was much more efferent, sending messages to organs, but it's now known that the sympathetic nerves, 80% of the sympathetic influence is an afferent, is sending messages from the body to the brain. And it goes along the dorsal root ganglion into the spine. And this dorsal root is the back of the nerve root. And if we're talking about a problem in this area that is related to this whole sympathetic afferent supply, this is the dorsal root ganglion. Is the area we need to investigate. Now, you sent me a heading for this summit on ME and fibromyalgia and long COVID. It was covering everything, was it, or was it just more?
Yeah, not as much fibromyalgia.
But fibromyalgia, a lot of people get told they've got fibromyalgia when they've got ME CFS. And the reason why they're told this is they see a rheumatologist who might not recognize ME CFS, but recognize fibromyalgia. And they used to have trigger points that actually most rheumatologists used to press really hard and say, yeah, you've got fibromyalgia trigger points, you've got the condition fibromyalgia, and some pressed too little, and some people didn't know where to press. So there was a major confusion. So the American College of Rheumatology came up with a new criteria for fibromyalgia, said that basically is a syndrome where if you actually look at the list of symptoms, it's very similar to ME CFS, CFS ME, with widespread pain in all four quadrants of the body. Yeah. And this is what is now being accepted. So you go through the symptoms, and the symptoms are very close to ME, except they've got more widespread pain. So that's why my new book is about fibromyalgia as well as ME, because I think the pathology that causes one leads to can also lead to the other. Mm-hmm. So my theory started with this cyclist. So I had to work out what was going on. So I reckon that it was the sympathetic nerves firing to the brain, and which part of the brain it would go to. The main part would be the hypothalamus in this part of the brain. And I also thought, well, if sympathetic nerves are affected, what's the main chemical used by sympathetic nerves as a neurotransmitter? And that's noradrenaline, what Americans know, what you call norepinephrine. And norepinephrine or noradrenaline is produced in the brain, produced in the adrenal glands, but it's also produced in the brain in an organ called the locus coeruleus, which actually should be blue because it's a slight bluish hue to it, because noradrenaline is slightly blue. And in the brain, that's why it's called locus coeruleus. Unfortunately, I've used a bit of Van Goghian license to change the colors. So yeah, I'm not colorblind. So locus coeruleus for you Latin scholars does mean blue spot, and that contains a lot of noradrenaline or norepinephrine. So I thought at 2004, before I wrote finished my PhD thesis, I said, this must be related to the whole of the drainage system of the brain, because I felt that the lymphatics and the brain were connected, but we didn't have the evidence to show this. So what I said, and my hypothesis at the time, was that ME, CFS, chronic fatigue syndrome, and fibromyalgia, I believed at the time, were problems affecting the sympathetic nervous system in the spine and the brain, and it caused a problem in the lymphatic system that led to a buildup of toxins in the brain and spinal cord. Because I said that the lymphatic system of the brain was not draining out correctly. In fact, it was pushing the wrong way. Now, this was a major problem in my whole rationale, because the drainage of the brain to the lymphatic system was completely out of the universe compared to when you consider what medical teachings for many, many years were given to the medical world. What the medical world said, there is a lymphatic system, yes, but not in the central nervous system. There's no need for a lymphatic system in the nervous system, in the central nervous system, in the brain and spinal cord, because large toxins can't get there in the first place, because there's a barrier, the blood-brain barrier, stopping any large molecules getting into the brain. And therefore, we only need blood in the brain, and we have blood, and we have the venous sinuses, which drain the blood away from the brain. We do not need a lymphatic system because large toxins can't get in. And if large toxins can't get into the brain, then obviously there's no need for a lymphatic system. So when I came up with this theory in 1989, and throughout the first part of my work, and then I published it in 2005 in my thesis, it was completely against medical thinking. And it's amazing, I did get a doctorate out of that, from something that was completely out of the blue. We did, my theories were that if we stimulate this cranial, this drainage system, and we stimulate the spine, and we get the lymphatics working better, and we get the sympathetic nervous system less irritated, we could help the patient recover. And we did a controlled trial showing that in my patient group, 40% improvement compared to a control group that were randomly chosen by the national organization in the UK, Action for ME, and they chose 40 matched control patients, age matched, and they got overall, they were told, go out and get better however you want, not with physical treatment. And in those days, in 1990s, when the study went on, nothing there's no treatments really for ME besides the old graded exercise and pace. But there was pacing, but there was graded exercise, and CBT was given, and drugs, and they were given lots of antidepressants. But the patients could choose anything they wanted to. They wanted to go to acupuncture, they could have done that. They wanted to go to herbalist, they could have done that. They could have gone anywhere. And they got overall worse by 1%, and our group improved by 40%.
40.
But this was totally ignored by the scientific community because they didn't do a double-blind trial with drugs, so as in drugs, so because it was manual therapy. So they just poo-pooed it as a waste of time. But it showed quite clearly in a years-long study that all my patients started improving in all aspects of their illness, from cognitive, depression side, anxiety, back pain, and energy-wise, and all the symptoms of ME were improving, and overall a 40% improvement. And this was completely ignored, which is a shame, because we developed this paradigm for research in those days, which was has now just caught up. It's the patient-related outcome measure paradigm, but in those days it didn't have PLOMs. So we had 8 different patient-related outcome measures, all showing improvement, and they just ignored all of them.
Yeah.
So
I hope that we're going to be spending more time focusing on those. And I do have a question for you. So you said that the spine of someone who has developed ME/CFS does have a particular trend.
Yeah.
Right.
And the cranium as well. because it was always known in those days that, besides the uppy flu, it was known as post-viral fatigue syndrome.
Yes.
And this gets on to the long COVID. So it's always called post-viral fatigue. And I said, no, it's pre-viral. The problem is there before. The virus is the final trigger. But if you look at the body on the biomechanical level, there's lots of things going wrong before. And I published a paper in the British Osteopathic Journal in 1993, looking at the ME from a spinal perspective, looking at that side of things from a biomechanical perspective, which hadn't been really done before. At the same time, I must say, for people who do know, in the US, similar sort of time, there was a wonderful doctor, Professor Peter Rowe at Johns Hopkins University in Baltimore, and he was doing similar work and seeing the same things as I was seeing, that the spine was very much related to ME, and he's published a few papers which mirror what we're doing as well. And we had the pleasure of having a conference together last year. I invited him to one of my conferences that I put on, and he's been following my work for years as well. So, we're in the same camp. So there are other doctors out there who have noticed this. I'm not the first, I'm not the only one, but I've done the research work needed to go further, and so has Dr. Peter Rowe and the Johns Hopkins team. So
it's amazing to me that so many people, now because we had the pandemic, like we talked about before we started the recording, you kind of hypothesized that we were going to have a lot of people with these post-viral syndromes afterwards.
Well, once I saw the similarity, what was going on, we realized that this is going to be a major problem after the pandemic has been sorted, and hopefully with the vaccination program and all the measures taking place around the world, we'll hopefully see a reduction in symptoms in patients which we are seeing in the UK and the States and other places now. But then there's the post illness. Then there's this long COVID, as they call it, or post viral fatigue, post COVID-19, and we're seeing this. And we knew this would happen because of the pathology. And this is what I want to explain to you.
Mm-hmm.
You use my model of ME, of post-viral fatigue, then you can see exactly what's going to be happening with COVID and why it causes this long COVID syndrome. I know exactly why this is happening, and it's all from a neuroscientist point of view and osteopathic point of view. So that's what I want to explain now, because this hopefully will be mind blowing to some of the people watching this for the first time, watching my work, because it's going to open their eyes and they'll understand. And one thing, Laurie, that everybody says to me when I've given a talk or that they've read my book, they all say the same thing: it makes sense.
Yeah.
And science is nothing but organized common sense. That was Samuel Butler said that.
I love that. Are we still going to be using the slides there?
Yeah. Okay. So
Okay.
if I can just show you a few more slides.
Yeah, definitely.
So this is a lymphangion, one little collecting part of the collecting vessel. And you can see there there's smooth muscles in the lymphangion, which are controlled by sympathetic nerves. So sympathetic nervous effects, and this is the thoracic duct, all that is controlled by sympathetic nerves pumping the lymph out into the bloodstream there. This is how big the lymphatic thoracic duct is. It's only the actual diameter is very, very small. So the actual lymph vessels around the body, which surface, are so small you'd never see them with the naked eye. They're minute, and that's why we can only see blood and blood vessels. When we look through the skin, we can see our veins. We can't see any lymph. And lymph has a colorless fluid in the skin, so you'd never see the lymph normally. Now, this is the blood-brain barrier I was talking about, that there's tight junctions stopping any large molecules getting in. So it's this hypothalamus that we have to look at if there's a sympathetic nervous system problem. And if this drainage doesn't work, this is the area we need to look at why it's not working, what's going wrong with the hypothalamus. And I said the locus coeruleus earlier, because it produces the major chemical involved in the sympathetic activity. Now, the human insulin protein has got 51 amino acids. Its molecular weight is 18 Daltons. 5,808 Daltons. And the molecular weight of water is 18 Daltons. Why did I show you this slide? Well, water, we know water carrying molecules, water can get through the blood-brain barrier. It's small enough. But large molecules like insulin, no way can they. 5,808 Daltons, it's whopping. I like the use of Daltons because John Dalton, who it's named after, was actually a Mancunian from Manchester. So that's why. But 5,808 Daltons is walloping. And when I gave a workshop in New York years ago, one of the osteopathic physicians said to me, "Ray, we love your work, but this is ridiculous. There's no way insulin can get through the blood-brain barrier." But it does. We know in the hypothalamus, insulin, the hormone insulin, has receptors on the hypothalamus that are attached to. So insulin and all other hormones get through the blood-brain barrier. How can they do so? And this gives a clue to the whole illness. And it also gives a clue to why women get ME much more than men because of the hormonal changes going on. And it also gives a clue why women are getting long COVID much more than men, because it's hormonally linked as well. So let's go further. In the brain, we have 7 areas called circumventricular areas that have gaps in the blood-brain barrier, allowing large molecules that the body needs to use, the brain needs to work on to function properly, including hormones, including electrolytes, and other chemicals that the brain needs, and they're too large to go through the blood-brain barrier. So in those areas, there's major gaps in the blood-brain barrier, especially here in the hypothalamus. And these are 7 regions that, as well as allowing large molecules of good stuff, it will allow large molecules of bad stuff going in as well, of the toxins. So once we know that, and this is fact now, medical fact, scientific fact, then what does the brain do with all these large molecules if it hasn't got a lymphatic system? And the answer is it has to have a lymphatic system. So where is it? And let's talk about something very, Jared Young is a professor at Alabama University in Birmingham, Alabama. He is also used to be in California at Stanford University, where he discovered there were 13 different cytokines found in the brain in ME. And this is a study that's going on, and there's neuroinflammation in the brain of ME, and this is what Professor Young has discovered, and he's got ways of testing for neuroinflammation. He's got scans, you can see the neuroinflammation. But cytokines are now in the press big time with COVID. Everybody's heard about cytokine storm. So what are cytokines? Cytokines are basically protein molecules that are signaling molecules to the antibodies, to the body's ability to kill the bug, kill the virus, kill the bacteria, but it needs to know what to kill the bodies. So these are signaling molecules. They attach to the virus, to the bacteria, and they say, "Cooey, we're here," and then the antibodies will come along and attack. And it's used. People know about cytokines for years because they're used in chemotherapy. Big time, they give large amounts of cytokines to attach to the cancer cells, and then the cancer cells will be beaten by the body's immune system, hopefully. But the thing is, we know when you have loads of cytokines, like with chemo, they're going to attach to healthy cells as well. And this causes the reaction that you see, that people lose their hair and all the rest of it from the cytokine storm that is being purposely given as a treatment for cancer. And this is what's happening with major viral loads. If a virus hits you big time, it creates massive amounts of cytokines, and this cytokine storm could start hitting not just the virus, but healthy cells as well, causing like autoimmune disturbances, causing inflammation. A lot of the cytokines are pro-inflammatory. And pro-inflammatory. And mind you that nowadays there's at least 17 cytokines discovered for ME, and that's the latest work from in Stanford. But leptin was something was mentioned by Jared Younger, that leptin is a female hormone, more female hormone than male, that controls satiety and hunger, and that was very much connected to the symptoms of ME/CFS that he discovered. That as the leptin went up and down, so did the symptoms of ME, and the leptin is very much closely connected with all these other cytokines, and it's again another reason why women might get ME much more than men. So where does this, and this comes to the whole point of my lecture, to talk about long COVID, and I know we're running out of time quickly, so I'll go quick. Where does it occur? It occurs in the perivascular spaces along the in the brain, and along, this is the outside of the brain, the meninges, the membranes of the veins. When those get inflamed, that's what meningitis is. And you see this blood vessel here, and there's a space around it called the perivascular space. And we discovered, other people like Roy Weller in Southampton talked about this drainage of the brain going through these perivascular spaces next to the blood vessels that supply the nerves, especially in the olfactory area, the area for smell, and so also the optic.
Sorry, just to clarify, the slide that we're seeing right now, this is within the brain.
This is the brain of a rat, and it's a diagram showing the brain's drainage of fluid out through new perivascular spaces into the lymphatic system, into the cervical lymph node in the neck. But this was all hypothesis. He injected dye into the rat, and it developed, and it saw it end up in the cervical lymph node. So he hypothesized it was going through this area, through the optic pathway as well in the eyes, through the trigeminal in the cheeks, and the auditory in the ears. And this was theoretical because we had no absolute visible proof that this was actually occurring. And there was another lady, Helen Sir, in America, that said this was happening in humans. Again, it was all theoretical, and also down the spine as well. So if the toxins are building up, we knew there must be a drainage system. This was the hypothesized drainage system. And this was the cribriform plate, which is a plate that allows olfactory nerves to go through from the brain, through this part of the ethmoid bone, which is, we're seeing the top part there underneath the brain, and it goes through these perforations. You know, the olfactory nerve, you have a perivascular space filled with cerebrospinal fluid around the blood. And this is was the theory, and I said this system was going wrong, was being back, not just draining out, but draining back in. There was a backflow going on, causing a disturbance of nerves in the hypothalamus, and the sympathetic nervous system in the brain, which then affected the sympathetic control around the body, including the lymph. So a vicious circling ensued. As you got more toxins building up, it caused more backflow of lymph, which caused more toxins to build up. That was my basic theory. But we had no visible proof that this actually occurred, because science hadn't caught up with my ideas or the other people's ideas yet. And that all changed in Rochester University in 2012, when Jeff Iliff and his colleagues in the university there used a new type of scan called dual photon emission tomography that showed this space, and it showed this space, and this space was, if it did contain cerebrospinal fluid, would show up on the scan as bright green around a middle part, which would be the blood, which would be in black on the image. And this is the image that came up. So it showed exactly what we were saying. This green here is a dyed fluid of cerebrospinal fluid, and it's large molecules from, and the research they were doing was on amyloid beta, which is for Alzheimer's. And the early symptoms of Alzheimer's are very similar to the symptoms of ME.
Oh, wow.
And it's the toxins that they said were building up in the amyloid. So they dyed the amyloid and saw where did these large molecules of protein drain away. And if it was green, it meant they drained away in this area. And this was the perivascular space. The blood it was all clear. So it was following the amyloid was following this drainage system. And this is the area where they stopped it draining. They did some very clever stuff, and they stopped the drainage, and they saw where it was building up in the area of the hypothalamus and this area of the brain, mainly in the thalamus and the basal ganglia, which is a big bundle of nerves, which are part of the limbic system, the emotional side of your brain. So when your whole toxic buildup happens, when the drainage doesn't occur, when it drains the wrong way, this is the area which it will build up in the emotional side. So that's why people have mood swings with ME, CFS, and severe anxiety, depression, secondary to the illness. And this is happening with them with long COVID as well. And the hypothalamus is right next to this all, and this gets poisoned as well. So this is building up. But the main thing I want to show you, this diagram, it explains everything that's going on, because it's a junction box, this area, between your thought processes in the frontal part of your brain and the doing part of the brain in the back. The seeing, the talking, the walking, the movement. So when this gets poisoned, everything becomes a chore. Everything becomes more difficult because the poisons are building up, stopping the connection from thinking to doing. And this is what's happening. And this area of the brain is all affected big time as the toxins build up more and more and more, because the olfactory pathway goes through this area into the brain, affecting this area of the brain into the hypothalamus and thalamus and basal ganglia. And they're involved in pain. Thalamus and basal ganglia are very much involved in pain receptors. And you'll find there's a lot of people with a severe pain everywhere in the body. And that's when they get to the fibromyalgia point of view. But this is happening with long COVID as well. But the olfactory is a real big clue. Patients with COVID are losing their sense of smell. That's one of the first symptoms a lot of them having, because this drainage goes in through this pathway, main pathway, affecting smell. It might go through this pathway through the optic nerve and affect the eyes. It might go through the cheeks into the trigeminal nerve. It might go into the auditory nerve, affecting the hearing. But the more common is the main one is the olfactory pathway. Then it goes into the hypothalamus, affecting a part of the hypothalamus that controls fever. So when the toxins, when all these inflammatory cytokines hit the hypothalamus and hit this part of the hypothalamus, the supraorbital cortex nuclei, it then leads to a mass fever in the body, a very high temperature in the body. And what's the first symptoms of COVID in most people is this loss of smell, or loss of taste, which is the same pathway, and then you get this high fever. And this, straight away, I realized this was going on. And we know from the past, from SARS, it's been going on. In SARS, the coronavirus that affected people in Hong Kong, and it transferred in 2003 to Canada. And a few hundred people died of it. And the survivors, a lot of them got severe ME symptoms.
Yeah.
And they did postmortems on some of the ones that weren't lucky to survive, and they showed that the virus had gone through the olfactory pathway into the hypothalamus. This was research done by Harvey Moldowski and his team in Toronto. So we knew this was occurring in SARS, and since COVID-19 is very closely connected to SARS, we thought it was originally called SARS-2. It's wrong to think of it as an upper respiratory tract disease, think of it as a lung disorder. It did affect, of course, the virus hits the lungs, but it's more a neurological disease, more a brain disease. And the hypothalamus is all to do with that. And just to finish this part of my talk, just to show that since then they've discovered that the perivascular spaces drain into vessels lining the brain that we now know, that we knew in 2015 existed in mice, that they had, the mice had these vessels, and there were true lymphatic vessels lining the brain in the meninges that nobody knew existed. So this was proof that the lymphatic system did exist in the brain, but only in mice. And also, they've also discovered that the main drainage occurred, and we go back to that one, the main drainage occurred during delta wave sleep. And they looked at the brain during delta wave sleep, and they looked at what was going on. This was going back to Ilif's study in 2012 in Rochester. They found out that when they slept and the drainage occurred during delta wave, the deep restorative sleep, the hypothalamus, locus coeruleus axis switched off. So they discovered this was the important part of the drainage system that I had hypothesized in 2004. In 2012, 13, they proved this for that there was this drainage system that switched off during the day and switched on during the night to allow deep restorative sleep to drain off all the toxins. And they found with ME patients, this is not occurring. They're not getting the delta wave. So Stanford University discovered that delta wave, they get sleep, but they don't get restorative sleep. And this is happening again with long COVID, that they're not getting restorative sleep. You wake up the next morning still feeling terrible. Stanford, Marcy and Mark Zinn, husband and wife team in Stanford, discovered that delta wave occurs during the day in ME patients. So during the day, you're having the drainage system. This area is switching off during the day, and at nighttime it switches on. You get wired and fired at night. You can't switch off. You can't go to sleep because this is all firing off the hypothalamus and the locus coeruleus, which stimulates norepinephrine. Noradrenaline makes you all wired and fired like adrenaline. So this is actually occurring the wrong time with ME and long COVID. So this is going to affect the sleep big time. And then the pièce de résistance of the whole thing was getting it to find it in humans. And I had to wait till 2017 before, it was 10 years after my book was published, it was 12 years after my thesis was published, and this image came out. And this is the first 3D render. It was a 3D on the web. You can actually see it in the 3D rendering. But all those green there is the dual lymphatics of a 47-year-old woman. So we do have a lymphatic system in the brain, and this is proof positive. So then they were saying, wow, this could be amazing that we now know there's a lymphatic system. It could, if this goes wrong, it could cause so many different disorders. And that's my work in one. I said it was ME and other disorders like Alzheimer's. And now there's been research done on Parkinson's, seeing that the drainage of the what they call the glymphatic system, what Jeff Ilif's team called and then Nedergaarden called the glymphatic system, which is a system of glial drainage, and glial are the packing cells of the brain where a lot of toxins lie. And these glial cells are drained away, so that's why they called it through this lymphatic system. So they called it the glymphatic system. And they now know that if you look on research, there's motor neuron disease is now linked to a problem in the neurolymphatic system. Parkinson's is. I've seen just a recent paper on epilepsy connected to it, and also my work on ME, CFS, for the last 32 years has been about this. And it's great to actually now for the last few years to actually have visible proof that I was right. So this wired and fired at night time and lethargic during the day, we know why you're suffering from that. And we know there's this backflow of lymph, and we know this causes varicose lymphatics that we can actually see here for the first time. These are varicose megalymphatics, and you can see them on this patient quite clearly because there's no blood, there's no color. If you see that, there's colorless fluid. This has to be a lymphatic that's become varicose as backflow. So this is proof positive that this is actually occurring in this patient with ME. And that this is showing that where the collapsed valves are. And this is another picture showing again, there's no blood, it's not bluish or purplish, it's color, same color as the skin tone because it contains lymph. This is a patient we took recently showing how big the lymphangion is there. And again, it's completely colorless. So it's the same color as the skin tone. And just to put Lynn Gilderdale was one of the unfortunately patients that died, and she had a post-mortem to see she had ME, and they found she had dorsal root ganglionitis. So if I was right again on that the dorsal root ganglion was the area to look at if it was the sympathetic afferent fibers. Sophia Mirza was another person, and also Marion Crofts, 3 girls that all died as a result of having ME. They were in terrible condition, and they all had post-mortems showing this dorsal root ganglionitis. And unfortunately, it would have to be done privately. They weren't looking into this until they actually had private post-mortems. So in a nutshell, ME, CFS, and long COVID, and fibromyalgia, and probably many other neurological conditions are due to damage from a physical perspective, could be genetic as well, and spinal cord problems due to spinal canal problems, affecting the drainage down the spine as well, and the buildup of different stress factors affecting the sympathetic nervous system and the hypothalamus, emotional trauma, physical trauma, all building up over the years. So we look back in this time that the person's had it, what's going wrong with the sympathetic nervous system? You can see they've had emotional, physical, immunological trauma, environmental trauma, other diseases, leading to just a second, I've lost my.
I wanted to hear what you were saying, and
sorry.
Yeah. If we can go
leading
back
to the next slide.
Oh, okay.
Yeah. So this affects the hypothalamus, and good stress and bad stress can affect the hypothalamus and the hormonal system, which is why women get ME much more than men. And also this backflow of lymph affects the breast tissue more than anything else. That's the first port of call. And therefore, the first port of call, is going to lead to just a slideshow from present. Sorry. I've lost, I think you, from current slide, yeah. Sorry. So this leads to sympathetic dysfunction, which causes backflow, which causes more toxicity and causing problems in the central nervous system, hypothalamus, and other parts of the brain, leading to ME, CFS, ME. And I just want to quote Abram Verghese, a famous doctor, lecturer in Stanford University, who said, "The doctor's round has become square." Said we don't examine the body anymore, but if you do examine the body, these are the physical signs you see with ME. These physical signs are the varicose lymphatics that I showed you about, spinal problems. There's also tender points in the chest, which are one of them. This tender point is known as Perrin's point, and it's due to sympathetic activity going wrong, causing oversympathetic activity, which causes a connection to the sensory nerves that lead to pain. And there's pain in the celiac plexus region of the sympathetic nervous system. That's underneath the rib cage, the area where boxers try and knock you out by hitting the sympathetics, and this It's also known as the solar plexus. And there's reduction in the cranial sacral rhythm, which is a very osteopathic term. Just to explain what the cranial rhythm is, and people might have heard of cranial osteopathy, we now know the thoracic duct pumps at 4 beats a minute. We know the heart rate stimulates is 50 to 100 beats a minute, and it's the blood that produces cerebrospinal fluid, which is the fluid that drains off from the brain into lymphatics, and that moves at 50 to 100 beats a minute. When you have, now we know this as a connection between the brain and the brain and the lymphatics, that the drainage goes into lymphatics. These two waves come together, and when they come together, they cause what's known as the interference wave. And that's a physical phenomenon, the interference wave. You know an interference wave when you've been to a beach, you see a big wave coming in, a small wave going out, they crash together, producing both. Producing a third wave, and that third wave is the interference wave. And in the human body, it's around 8 to 12 beats a minute, which is what osteopaths term as the cranial rhythm. And basically, that's all going wrong. This disturbed cranial rhythm is one of the signs. And we're seeing this with long COVID. And my techniques to help this is stimulate the cranial flow, stimulate the lymph drainage in the spine as well, reduce the sympathetic tone, reduce this errant sympathetic afferent supply, so that the wrong nerves are not firing off back into the brain. And it's what I call the concertina effect. If you stimulate the lymphatics going up towards the collarbone and down from the head towards the collarbone, you create a pressure. And that pressure forces the lymph to go into the central drainage. Together with effleurage techniques, standard lymph techniques, and petrissage techniques again, to get the muscles relaxed and to stimulate the lymph, we eventually get the patient feeling much better. And that's the Perrin technique. And just also we give advice on toxicity from an environmental point of view. Stay out of toxins, stay away from toxins. And this is an image that I took for a photo in Greece. And just a few weeks before, I was in a conference in China, in Chongqing, and you see the difference in the terrible state of the pollution in this city of 33 million people in Chongqing. And the toxins that are in there are in the Yangtze River. You can see how yellow the water is. A well-balanced diet is important, and we tell people to have a well-balanced diet. Acupuncture might help as well. And Euripides said the best and safest thing is to keep balance in life, acknowledge great powers around us. If you can do that, you're a really wise man. Balance is the key to health. You need good balance, like my son on the surfboard there. But Harvey Moldowski, I mentioned, in this picture, it looks so real now. Everybody knows what's happening in COVID. This was taken during 2003, during the SARS outbreak. Not much difference there. And just to show that, so we knew that SARS was going to be the SARS-2, that coronavirus 19 was going to be very similar. And unfortunately, it did follow the same pathway. And now in Germany, there was a study done that showed it's going through the olfactory pathway into the brain, through the blood-brain barrier. So it's following the same pathway as SARS did. And therefore, we knew my techniques could be helping, and we're helping them. Patients were getting from bedridden to health. It's all in my book. The treatment, if you can't get to a practitioner who's trained by me, and unfortunately I've not gone around the whole world yet, then if they get the treatment, the Perrin technique, it should be able to help them on their recovery program. This is a patient, Jade, who we saw. This is somebody with ME who was housebound for 11 years, wheelchair bound for 2 years before she started treatment. And this was her 18 months later. And this was her at the top of the highest mountain in England, Scafell Pike. And that's somebody who was almost at death's door. And the Perrin technique is now available at all good booksellers, and very shortly, because it's a very large book, it's over 500 pages, and it's too much for a lot of patients to read concentration-wise and stamina-wise. So we produced a concise Perrin technique handbook for patients that is out this summer. If you have the big book, you don't need the small book, but the small book gives everything you need as a patient to recover. So that is what I wanted to share with you. And I probably got loads of questions, Laurie, but I don't know if we've got time.
Yeah, I do want to take a few minutes just to ask a few questions. I'm particularly interested in, so before we started, when you and I were just chatting, you told me about a case study that you just had recently with a very young man.
So Harry was 12 when he first came to 14 when he first came to me. He'd had ME for 10 years, since he was 10, for 4 years before that. And his parents were desperate to help him. And I actually asked him last week, when you actually asked me, have you got any patients who were talking about the recovery? Harry had come in that week. In fact, the day after, I got an email from you, and the parents came in so delighted because they said Harry's playing football, going out, soccer you call it in the US, and he's going out doing everything he wants to do as a 17-year-old. His been symptom free. He hadn't had a treatment for 8 months. So I was seeing him for the first time in 8 months for a checkup, and he was able to do everything. I examined him, and all the physical signs that he had originally had all gone. He was completely symptom-free on the scale, and he was able to do everything he wanted to do as a young 17-year-old. And I discharged him. I have a scale of 0 to 10, 0 being dead. I always tell my patients, you're not 0, but you're not 10 out of 10 when they start, because that's perfectly healthy. And we get some patients to that magic 10 out of 10, and Harry was lucky to be one of those. So with treatment, weekly treatment to begin with, then we spaced out the treatment to monthly, eventually to every 3 months. And this last one was a checkup. It's normally 6 months, but I think because of COVID-19, it went to a bit longer. So he came in and he was fine. And I said to him, how did you feel when you first started with the treatment? He said, didn't believe a word you were telling me, as a typical 14-year-old boy. And his parents made him follow the instructions I gave him, because I have to give the self-massage routines to do, and exercise to do. And they do that bit, and he had the treatment. Now, it's interesting because treatment, obviously, if we did a research involving large numbers of patients, the treatment would cost, if we had other practitioners, I wouldn't be able to be part of the research. Obviously, I had to back off. But if we got a study done on long COVID, it would be interesting to show how the treatment helps. However, we need millions for that study.
Yeah.
But myself and a group of scientists and doctors at the local hospital, National Health Hospital, the Salford Royal in Manchester, together with my colleagues at the University of Manchester, are just about to submit a bid for a research we're doing, which involves just the self-massage and self-exercise program that I talk about in my book. It's not going to be enough to get them 100% better. We know that, but because they need extra treatment. But we've given as much as we can to them to do at home. And we're going to do this it's going to be a blind control study. We're going to take a group of patients, and it's going to be a study where we have a group of 50 or so patients who are going to have the treatment and 50 or so who are not. But then it's going to cross over. And then the 50 who haven't had the treatment are going to be allowed to do the self-management as well. And in that time, they'll be doing self-massage and gentle exercise to get spinal mobility, and there'll be techniques to help their cranial flow move better, which we can give. And these are all mentioned in my book and in my work. And we're going to do this and see, it's a feasibility to see if patients will follow the instructions, and then how the group who have the treatment will do. So we're hopefully expecting the first group after 3 months or 6 months really to really show an improvement. And then the second group will start, and then hopefully they'll show an improvement as well. It'll be interesting to see how, if they catch up to the first group or they're always lagging behind. And also, so it's a lot involved there, and we're hoping this to start this just after the summer. We're submitting. It's got to go through ethics, but it's very cheap. In fact, it will cost the NHS nothing because we've got a charity that we set up years ago who are paying for it, for the study to be done. And it's actually, we're supplying them, the patients on the study with massage routines, massage hammers, long massage, sort of long-handled massagers that they can use to massage their backs themselves. We're supplying them with cold and warm packs, because getting inflammation down in the spine is very important. And we use contrast bathing, naturopathic, warm and cool, and it really does the job. And so we're giving them the hot water bottle to use, a warm water bottle. We're giving them the cold pack. That's costing something, but it's nothing like a treatment would cost every week in surgery, in practice, in clinic. So it's very cost effective. And if it works, we'll do a much larger study, hopefully with government funding next time. And if that works, we'll roll it out throughout the world as a way of relieving the symptoms of ME. But you don't need to wait for the research to be done. If anything resonates with the viewers of this webinar, of this summit, if anything resonates, they can get the book and do a lot of treatments themselves. It's best to do it in conjunction with treatment from an osteopath, physical therapist, physiotherapist, chiropractor who has a knowledge of cranial. If you do it together, you'll have a much better result probably. But if you do it by yourself, you might find some relief. So we're hoping to see some changes for the positive, and then so that's an interesting. But going back to Harry, he didn't want to do anything, but his parents forced him to do week by week the treatment, and he improved. And eventually we discharged him last week, and he's 10 out of 10.
That's just beautiful, and I'm hoping to speak with him and his parents as well. And you know, Ray, thank you so much for this. Thank you for your book. Like you said, if people do resonate with it, if you guys are resonating with this, then you know, try it out for yourself. And I'm so excited to hear the results of this experiment that you're doing.
Yeah, but we're doing it in clinic now all the time, and all my practitioners around the globe are treating long COVID and are having good successes. So we're seeing this, and we've got hopefully a paper coming out showing early results of the first 20 patients who had the treatment, showing how well they did. And some of them are symptom-free completely. The quicker you get the treatment, the better. So it will help. So hopefully it made some sense to you. I hope I didn't gabble on too much. You have to stop me talking sometimes. So, and you've got a wonderful array of other speakers to listen to hear from them as well on this summit. So I hope you enjoy all their words of wisdom as well.